Hey, what's up, guys? This is Chris Fox, going to give you a talk on blocks unblinded, ultrasound guided nerve blocks, and yeah, I work at UC Irvine. I've been there for 23 years and doing a lot of ultrasound over there. But the actual expert on ultrasound guided nerve blocks is this gentleman right here, Dr. Arun Nagdev at Highland. And if you go to highlandultrasound.com, you'll see that's kind of where I go every time about to do a nerve block that I'm unfamiliar with. I go there and review it first, and there's the QR code for that. But good buddies, I look up to him for all things life, and also ultrasound guided nerve blocks. So the goal for doing these nerve blocks, of course, is to decrease the pain when someone's getting a procedure or reduce the need for sedation. Super helpful. Unstable patients you don't want to give parenteral opioids to, and of course, reduce the use of those opioids, decreases the length of stay, and increases patient satisfaction scores. Literature has borne all of this out, which is why we're really interested in doing it. Because when you do it under ultrasound guidance, you can see the needle going directly into where the nerve is, and then you inject the lidocaine, and then you can see that anesthetic spread out in the area around the nerve, and then you can really get a sense of the nerve itself. You can see it's this honeycomb structure here. But again, we're watching the needle go across under the plane of the ultrasound beam, and we can see the entire needle. We place it in, we inject the lidocaine, and then we pull the needle back out. And so we nicely get the lidocaine to bathe the entire nerve. And if you wanted to stop right here with this talk and be done and go try a nerve block, you could probably do it. But it's good to review a whole bunch of other things too before we get there. But that's the whole crux of it. When it comes to trauma and orthopedic injuries, there are certain situations where you would not want to do a block, and I'm going to go over that. First of all, start with the blocks that are okay. We don't have to talk to ortho at all. We just do this block. And that would be for things like a shoulder dislocation, clavicle fractures, humeral fractures, low energy distal radius fractures, which are incredibly common. Hand and digit injuries, also very common. Hip fractures and dislocations, depending on our patient population, can be really common. And then other low energy foot and ankle fractures. So I think about this here when the majority of the blocks that I'm going to do are pretty much okay. And I'll contact ortho, of course, for any admitted patients, but I don't delay the block for that. Whereas in these situations where there's a humeral shaft fracture, an elbow fracture, or both bone forearm fracture, femoral shaft fracture, these tend to be higher energy injuries, and um, I document a really good neuro exam, and then I consult, and then I do the block after the consultation. So I talk to ortho before I do these blocks. And then these are blocks that I would not do, these are injuries that I would not do a block for. These tend to be high risk for compartment syndrome, high energy injuries like a tibial fracture. It takes a lot to do that, or any high energy forearm fracture, foot fracture, or anytime you're worried about neurovascular compromise, because you got to be able to assess for compartment syndrome. And if you block this area, you reduce that ability to assess for that, and somebody could totally develop compartment syndrome and nobody would know about it because they're pleasantly anesthetized. So again, just best practices here. You want to do a really good, thorough, detailed, and appropriately documented neurologic exam before the block, and do a thorough, detailed, appropriately documented compartment exam before you perform that block. Now, which local anesthetic are you going to use here? And I refer to this table again. It's at that website that I referred you to from Highland Hospital. And you can see here there's ropivacaine, bupivacaine, lidocaine, lido with epi, mepivacaine, and chloroprocaine. I have to say I tend to use bupivacaine the most, along with lidocaine. And so if somebody has a lidocaine allergy, we'll usually switch to bupivacaine. Um, just know that with bupivacaine, there is a greater risk of toxicity than with lidocaine, and that is also contraindicated in pregnancy, as well as mepivacaine contraindicated in pregnancy. But the other thing that I really keep in mind when I'm doing any time I'm using any of these anesthetics is the dose range to make sure that I don't go beyond a maximum dose. depending on the body weight. And so that, because you really don't want to induce last, which is lidocaine anesthetic toxicity, systemic toxicity. And so when people get this anesthetic toxicity, when we start getting up to that higher dosage range, they start saying, oh, my tongue is getting numb, or I'm feeling lightheaded, um, or any visual disturbances or twitching. Boy, I'll tell you, I'm getting out that intralipid. I stop what I'm doing and I run and get the intralipid right away. And we have that in our ED ready to go with the intralipid. And I think it's good to kind of review with your ED pharmacist uh, to make sure that you have easy access to intralipid. So this local anesthetic systemic toxicity, you could think about the mnemonic ACLS and then SLE if you want. I really don't like mnemonics personally, but it's one way to talk about it, I guess. So if you do have this, you want to use low dose epi to avoid vasopressin. You also want to avoid calcium channel blockers, avoid beta blockers. If you do have a ventricular arrhythmia, you want to use amiodarone and avoid any class 1B antidysrhythmic agents. Stop any seizures with benzo, avoid propofol, and you're going to use that lipid emulsion therapy. It's called 20% intralipid, and you can bolus it, and then you can drip it in. And then the E stands for ECMO. Hopefully it doesn't get to that. So not to scare you, but there are some complications other than the anesthetic toxicities that can occur, such as an intraneural injection, and that's why ultrasound is so helpful to bathe that um, anesthetic around the nerve. You don't want to get into the actual nerve itself. Um, Depending on the type of block you're doing, if you're doing a block up in the neck area, you could get some unilateral diaphragmatic uh, paralysis. If you're doing a brachial plexus block or interscalene block, that's something to think about. And that's so if you had somebody with shortness of breath before you did the block, or COPD, or you wouldn't want to decrease their drive to breathe, and so you'd avoid doing interscalene or any kind of brachial, in my opinion, a brachial plexus block. Now, also you want to, we already talked about, the local anesthetic toxicity. So how does this work? In plane, out of plane. What do I mean when I say in plane, out of plane? Basically, you could get the needle in a cross section. That means out of plane. The problem with the out of plane is you don't know which part of the needle you're dealing with. Is it the tip of the needle? Is it some other portion of the needle? Because it all looks exactly the same on the out of plane technique. Again, the probe's in a transverse position. However, when you're in the in-plane technique, it's much easier to see the entire needle tip and shaft, and therefore you can guide the needle down to the vein. That was the preferred method for doing nerve blocks. But you're probably used to the out-of-plane technique when you're doing ultrasound guidance for IV access or central lines, because it's just there's so many things going on. You've got the needle, you've got the vessel, and it's just and you're trying to get the needle into the vessel, and so in those cases, it's probably easier when you're doing vascular access to start in the out-of-plane technique, and then you can switch to in-plane. So a lot of us are used to that kind of um, out-of-plane technique. But when it comes to nerve blocks, you want the nerve to be out of plane or in its cross section or its short axis, and you want the needle to be in its long axis across the screen. And so that's what this looks like here. We can make out the needle right along here. The nerve is down here. So the needle is the in plane. It's underneath the long axis of the sound, longitudinal plane, and other people call it. And then the short axis here is the nerve. So the nerve is like coming from behind the screen and then coming out towards you in its cross section. All right, so a nerve block box, what's important here? I think it's great to put a little box together. You can just order any old small box you want on Amazon, and then find these things. You want to have a Lida with epi, you want to have intralipid. Some of that stuff needs to be stored in the pharmacy per hospital regulations, but so you need to order that, usually. But then in this box, I always have my control syringe with the thumb holes like the dentists use. So that's called a control syringe with thumb hole. And you can tell your folks to order that. And then a 3.5-inch spinal needle, and then tegaderms. Put the tegaderms on the probe to keep the probe sterile from the patient's skin. And you're going to use a linear probe. You use tons of ultrasound gel, and then you're going to make sure that you adjust your gain and your frequency so that the muscle tissue in the target area is kind of dim, so that the nerve tissue becomes more brighter than the muscle tissue. It's a little subtle, takes a little bit to get used to that. And then in the room itself, you don't want a bright background to obscure your ability to identify discrete structures in the scene on the ultrasound screen. So yeah, dim the lights in the room, and kind of modify the gain and frequency. So nerves, how are you going to find the nerve? Well, they run along borders of other structures like muscles, and so you're going to look for muscle boundaries, and then keep in mind that what would seem like a minor change in the probe angle can cause the ultrasound beam to encounter the nerve at a more advantageous angle for reflection. And so this concept is called anisotropy, and it looks like dropout. So when you're looking at the nerve, sometimes the nerve looks really good, and then you turn that, you angle the probe slightly differently or rotate it, just a minor change, and all of a sudden you're like, wait, where'd the nerve go? And so it didn't disappear. It's just this concept of anisotropy. You just want to make sure that you see the nerve um, in its full glory by making sure you get the probe just right over it, and avoid anisotropy. And then you want to have your supplies in front of you, not like I'm doing here with the supplies behind me. You want to have it sort of out in front of you so that you can continuously keep your eyes on the screen. And then you're going to move the probe up and down the selected nerve. And we can see that when we do that, the nerve kind of starts to pop out at us. There's going to be a lot of targets on your screen. So I start by just moving my probe up and down the area a few times to make sure that I'm looking at a nerve. If it disappears after a short distance, it's definitely not a nerve. But if it bifurcates, it's a nerve. Nerves will bifurcate and come back together as you move the probe up and down the region. Now, tendons, as you can imagine, can look like nerves on ultrasound. A tendon, though, is a very fibrillar structure. You can see this fibrillar structure here. That's a tendon. And tendons tend to be more hyperechoic from a lot more different angles than nerves are. And so, and tendons are closer down to the bone when the nerves are more superficial on the screen. And as you move the limb back and forth, flex, extend, whatever, you'll see the tendons moving as well. And so that can help when you move the tendon. And then, of course, you want to make sure that you don't put the lidocaine into a vascular structure. And you can use Doppler to help discriminate a vascular structure from other targets. But whenever you use Doppler, of course, you got to hold the probe really steady so you don't cause artifacts. So get everything nicely organized, and you want to focus on the target during the needle placement injection, sitting down. I do this every time sitting down. And then you want to not inject all of your solution with a single placement. You want to sort of get that solution around the entire nerve. You want to bathe the nerve in that solution. And know that the reason why blocks tend to fail is that the lidocaine can drain into adjacent compartments, because these nerves run along the spaces between the muscles, and the muscles are divided by the fascial membranes, and it's really easy for the to be on the wrong side of one of these fascial planes, and that local anesthetic can just go completely away from the target nerve. And so what happens is that the medication doesn't get to the nerve, and of course you get a failed block. So you really want to make sure that you bathe the area of interest. Here's the nerve here, and you can see they're just getting it to hydrodissect or bathe the entire region. And so to do that, you could see it being bathed over here. I would probably withdraw the needle a little bit and then do the same thing on this side of the nerve as well. And so completely bathing. Of course, you're staying away from this blood vessel down here. And you can see as we hydrodissect, the blood vessel is not involved at all. It's all around the nerve. And so with a femoral nerve block, that's one of the more common, if not the most common nerve block I do. And it's amazing to be able to provide that immediate stop all that discomfort in your elderly patients with hip fractures without having to snow them with narcotics. And so this is an important block to learn. I would call this a worthy opponent. The patient, so they should be supine and then abduct their leg, and then you're going to put on the tegaderm. You can use plenty of gel, and then obtain the transverse plane at the inguinal ligament with the probe, and then you're going to locate that femoral artery just lateral to the vein, and the nerve is going to be lateral to the artery because we know because of navel. And so you're going to take a nice 3.5-inch 22 gauge spinal needle and bring that down to the target, and then you're going to divide that anesthetic. And so if this is your ASIS and your pubic tubercle here, you're going to be about a third of the distance between the ASIS and the pubic tubercle. So you're going to be closer to the ASIS. And then that's where you're going to basically insert your needle, and you're going to see the needle go underneath the plane of the sound. Again, nerve, artery, vein. It's a pretty straightforward block to do. And what happens is you're really looking for that fascia iliaca. So here's your femoral nerve right here, femoral artery, femoral vein. And again, the more lateral structure of the femoral nerve. But look at this, it's a little bit hypercoic, this fascia iliaca. And so this is the area here that you're going to want to get the anesthetic to go underneath the fascia iliaca and then bathe the femoral nerve as well. And so again, looking at the other side, again, the vein is more medial, femoral artery more lateral, your femoral nerve is more lateral to that. Here's your fascia iliaca coming across here, and you're going to bring that needle just lateral to that femoral nerve underneath the fascia iliaca. And this is the area where you get the best results for doing the femoral nerve blocks. Okay, so on this kind of more fuzzy, grainy image that we tend to see, more lateral, again, is that femoral nerve, and then here's that fascia iliaca coming across right here. Fascia iliaca, femoral nerve, iliacus muscle. All right, so we're looking now, we've got the femoral arteries here. The femoral nerve is in this region, and we're bringing that needle in, and that fascia iliaca is coming across down here, and then that nerve, the femoral nerve, is being bathed in the anesthetic. Another great block is the serratus anterior nerve block. This one's super duper easy to do. It's great for rib fractures, chest tubes, abscesses. And basically, you're going to go sort of, you're going to look for those, you're kind of looking for the serratus anterior muscle and then the ribs, knowing that all these intercostal nerves emerged to the surface of the serratus muscle and then branch traveling anterior and posterior. And so you can kind of roll the patient on their side and know that the serratus anterior is in this region just underneath the axilla here, maybe that mid-axillary line. This is the region where I am. And I'm looking at the serratus muscle here, and this is the rib underneath it. And then you basically take your needle down and you inject right on top of that serratus muscle. And so this is the very common posterior approach that we'll use. And so if you want to come anteriorly, you could do that as well. You're going to see the latissimus dorsi, and then the serratus muscle, and then your rib down here. And again, you could put that anesthetic on top of that serratus. Is usually, I think, the better place. Some people say put it between the bone and the serratus. I like it just on top of the serratus. It works fine that way, and I'm not getting close to the lung. But again, these ribs are amazing landmarks, and so you'll see the rib, you'll see a muscle right on top of the rib, and then you'll just plop the anesthetic right on top of that muscle that's on top of that rib. Pretty easy to do. And you can see here, this is the rib right here, and the lung is down here. Rib shadow, and then this is the serratus muscle, and then all this fluid here. The needle's coming in from this side of the screen, and all this fluid is here sitting on top of that serratus muscle, but underneath the latissimus dorsi. Erector spinae block, boy, I'll tell you, this is like, no block makes me feel more like a magician than the erector spinae block. Here's somebody, this is who I do it on, classic situation where you've got somebody with chronic abdominal pain, and they're asking for Benadryl and Dilaudid, and they're writhing around in pain. I have to sign out in a couple of hours. I don't want to have to, sign this one out to my colleagues. So I want to get their pain under control. And definitely erector spinae planar block for the win. And I'll show you kind of how to do it here. You can see, looking anteriorly, this is the vertebral body, and then the spinal cord, and then the spinous process of the vertebra, and then the transverse process. Spinous process, transverse process. So we know that the erector spinae muscle lies in this little wedge here between the spinous process and the transverse process. And then our ribs come out over here. And so the idea is to, in this paravertebral space, is to, this is the region in which we're going to be injecting our anesthetic right here. So it's really where the transverse process is. Spinous process, super easy to identify. You're going to slide a little bit lateral, and there's your transverse process. This is posterior. So right away you're wondering, okay, wait a minute. Okay, I'm going to put the needle in the patient's back for pain in the front of their body, in their abdomen. And that's exactly right. That's why you feel like a magician, going in from the back, and then suddenly their pain in their front stops. And so, yeah, so it works great with the chest and the abdomen on that side of the body that you do it on. So here's what it looks like here. Here's our spinous process. We're using a curved probe here. You can use a curved probe or linear probe depending on the size of the patient. Here's our spinous process, and then lateral to it is our transverse process. Okay, and this is this region of the erector spinae. So I would bring my needle right down to the transverse process and inject all around here, right next to the transverse process. That is my landmark. So here's again spinous process. You've got a ligament, and then your spinous process is here. Okay, once I know where my spinous process is, I know that just adjacent to it, lateral to it, is going to be my transverse process. So the probe here is in a sagittal plane. Okay, that's why superiorly I see one spinous process. Inferiorly, I see another spinous process because my probe is sagittal. It's up and down, not side to side, not transverse. Okay, if it was transverse, well, then I'd see both spinous process and transverse process, but the probe is sagittal here. So I start on that spinous process and I move laterally, and initially I'm going to see the transverse process, and if I move even more laterally, I'll go, okay, there's my ribs, pleuris down here. All right, got it. Ribs, go more medial now, transverse process. And then I'm going to bring my needle right down to that transverse process. So I do this kind of like sagittal back and forth a few times just to make sure I'm looking at that transverse process. I go, okay, rib, that's definitely rib. Come back over here, spinous process. Yep, transverse process. And it looks a little bit like this, sagittal plane. We've got the transverse process here, and that's the erector spinae muscle there. And this is the area in which I'm going to be injecting my anesthetic. You can see the bringing the needle here just superiorly. This is in the thoracic area. And transverse process, the probe is sagittal. So there's one transverse process. There's another one. And here's that needle coming in. And the erector spinae muscle is here. And then we're just going to let that anesthetic bathe this whole plane right here. And so when it's going to go up and down the plane, the anesthetic will. And then you have this whole region here that you were able to accurately anesthetize. It's very, very effective because it's a plane, so you go up and down 3 or 4 vertebral levels where you inject, and so it's very effective that way. It's safe because you're in the chest wall, you're outside the thoracic cage, you're away from the pleura, you're also away from the spinal cord and any other deep vessels, and you can see the needle tip throughout the entire procedure. And the transverse process itself is pretty big, right? So it blocks the deeper structures in case you go too far, and it's such a great target. It's also pretty versatile and very quick. You can just get that patient prone, lateral, decubitus, or even sitting up, depending on your and their patient's preference. It takes about maybe, I don't know, 5 minutes? Yeah, maybe a little bit less. And I love doing these for if somebody who's got a lot of rib fractures, a lot of extensive wall trauma. So I could do that serratus anterior nerve block for those rib fractures, or I could do a erector spinae plane block. And the plane block is better because it covers a whole plane, 3 and 4 levels up and down from where you inject. It's great for herpes zoster, as you can imagine, vertebral compression fractures, and then all this abdominal stuff, appendicitis, renal colic, pancreatitis, narcotic bowel syndrome, and those difficult patients who have chronic intractable abdominal pain. Okay, next block I'm going to talk about is the popliteal nerve block. This one also very, very easy and very safe and incredibly useful. I'm saying the popliteal nerve block. It's really the popliteal fossa and you're you're going to target the sciatic nerve, which is proximal to its bifurcation into the common perineal and the tibial nerves. And so it really does a great job at the lower leg, ankle, and foot. I had a patient who was on Catalina who jumped off this thing and broke both his calcaneae. He couldn't walk, he was screaming in pain, and I had to transfer him in a helicopter over town. But this guy, I was giving him. Started with some narcotics, and then immediately went to this nerve block. And he was like, after I did the nerve block, he was just like on his phone talking like nothing was wrong with his feet at all. It was pretty amazing. And so you can see the region that it gets. It gets the foot really well. And it gets the area that's sort of the lateral part of the calcaneal area in the entire bottom of the foot as well. It does miss the medial aspect of the leg and the medial ankle. And so just know that that area is innervated by the saphenous nerve. And so if you did a femoral nerve block in conjunction with that sciatic or popliteal area, then you'd have full sensory blockade of the lower leg. So if you did this nerve block and they weren't having the effect you wanted because their pain was too medial, then you could go up and do a femoral nerve block. So this is what it looks like. It's a very easy nerve to see because you've got these great landmarks of the popliteal artery, popliteal vein. Those of you who already do DVT ruleouts, you will see this nerve very easily branch it into the tibial and the common perineal nerve. So you want to get a little bit more proximal to where they come back together, and this is where you want to block it up here, a little bit more proximal. So you can see down here they're a little bit too distal, and then they just moved it a little bit more proximally, and that's the sweet spot right there. Again, same spot you're going to rule out a DVT. And so you can see that tibial nerve here, very bright echogenic honeycomb structure above that popliteal nerve. Now, forearm blocks, they're pretty easy and they're pretty fun. You can easily see the three nerves in the forearm. So you could say the forearm of the ulnar nerve, FUN, forearm ulnar nerve. I don't know, that was kind of a silly dad joke, but this is kind of what it looks like here. So you've got the ulnar nerve here, the median nerve is here, and the radial nerve is here. And depending on which nerve you want, you can decide what needs to be blocked. And so again, we're coming across here. I can see what looks like the ulnar bone, the radius bone. The nerve is in its transverse view. This is likely the median nerve. Oh, it says ulnar nerve. Okay, well, I guess we're a little closer to the ulna. Maybe that's ulna over here. But again, I'd have to, when I'm doing these, like everything else in ultrasound, I like to kind of really march it out myself with a probe in my own hand to see all my landmarks. So yeah, but that's what the nerve looks like. That would look like median and radial nerve as well. And so here's a radial nerve block. It's always helpful to read the slide title first. Here's your radius bone here, and we're bringing that needle in. We're doing hydrodissection, and you can see the radial nerve is right here. Very straightforward, quite easy to do. So in summary, it's always safest to start with the distal blocks to get more comfortable with that technique, like those forearm nerve blocks. I don't know. Once you do one nerve block, I think you're ready to go, especially with the nerve blocks that we talked about. There are other nerve blocks I didn't mention in this talk that are more higher stakes, if you will, like the ones in the supraclavicular area, interscalene, that area. We didn't really talk about that at all. I think it's better to kind of get started with the ones I just mentioned. But certainly once you get good at these blocks, the ones we talked about, then you could start thinking about more advanced ones. There's a whole bunch of other blocks you can get into. Get all their supplies dialed in before and have that machine in your line of sight. I would draw plenty of anesthetic, but always know where your limits are with that. And then you're going to move the probe up and down the arm to get a sense of those nerves, and then you're going to try to get in 3 separate locations, and definitely don't stab the nerve. All right. Thank you very much. Oh, and this is your nerve block box. Lidocaine with Epi, intralipid, the control syringe, the 3.5-inch spinal needle, and the tegaderms. Thank you.